Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Welcome everyone to today's webinar, the No Pay Wrap, Lessons Learned and Things to Consider in 2021. I'm HHCN editor Bob Holly, and I'm going to be your moderator for this discussion. The No Pay Wrap has been a very hot topic in 2021, and I think that's reflected in the fact that we have well over 1,000 people signed up for this webinar. So before we go any further, I want to first say thank you to Axxess for bringing all of this together and providing this valuable insight into what's going on. Before I turn things over to our two experts today, I did want to go over just a few housekeeping items. First, please note that your phone lines have been muted to ensure sound quality. We can't hear you, but if you did want to ask a question or make a comment, please make sure you send those my way using the question box on your screen. I'm going to be looking through those during the conversation, and whenever there is a natural fit or toward the end of the webinar, I will send them toward David or Nick. We'll get to as many as we can, and hopefully both David and Nick won't get mad at me for throwing them too many curveballs. Lastly, please note that this webinar is being recorded. All attendees will be emailed a copy of the slides and a recording of the conversation following its conclusion. Without further ado, let's go ahead and meet our experts for today. First, we have David Hoover, the Vice President of Revenue Cycle Management at Axxess, the fastest growing home healthcare technology company. David leads the company's billing, electronic data interchange, and payer management service teams. To date, David's team has processed more than 14 billion with the B in Medicare and managed care claims. Prior to joining Axxess, David served in a variety of roles in the healthcare industry, providing operational and financial expertise for over 30 years. David, thanks for being here.
Thank you, Bob. Sorry, I had to get off.
No problem. Also joining us is Nick Seabrook, a managing principal and founding partner of BlackTree Healthcare Consulting, a national consulting firm that provides all sorts of billing, coding, and collections services for post-acute care providers of all types. Apart from his role at BlackTree, which, by the way, was recently listed on the Inc. 5000's list of fastest growing private companies for a fourth year in a row, Nick is also extremely active among the various state and national home health and hospice associations. Nick, thank you for joining us today as well.
Thanks, Bob. Thanks for having me.
All right. Well, now that those introductions are out of the way, I think I'll go ahead and turn over the virtual microphone to you guys. And again, I might interrupt from time to time just to try to get some audience questions in there.
Great. Thank you, Bob. Yeah, and Nick, I appreciate you doing this with me. This has been kind of fun to prepare this presentation because things were changing as we were making the presentation. So it is definitely a hot topic and a very pertinent one right now.
Absolutely.
So some of the objectives, just to review what we want to talk about a little bit here is, first of all, we want to review what happened on January 1st of 2021 this year as we move to the second phase of PDGM and the introduction of the no pay wrap. We also want to kind of analyze what that potential impact it may have on cash flows and what agencies may experience during this time. And then also talk about some operational changes that already may have been done by the agencies, but if not, then maybe something that may be considered to help with this transition. Also, we want to talk a little bit about technology and certain features that might be used to ease the burden on your resources so that there's not a lot of manual intervention. And then also we want to talk about what to expect for the rest of 2021. So let's go back and just talk about what happened January 1st with some of the no pay wrap changes. Again, this was a continuation of the final ruling for PDGM. And this is on the way to eliminating really the wrap as it exists originally, especially in PPS. And the whole purpose of that was that the wrap was something that was providing challenges to CMS to keep everything moving correctly and to make sure that people weren't abusing the request for anticipated payment and following through. So that was kind of the impetus of what these changes started to occur, with the change in PDGM. So originally in PPS, we had the 60-40 percentage split, so 60% on the starter care that you received in the request for anticipated payment, and 40% of the payment coming for the episode in the final. Any subsequent episodes were 50-50. When we moved into 2020 with PDGM and introduction of PDGM, we saw that percentage change to 20-80 for all episodes. Didn't matter if it was a starter care or subsequent billing period after that. So now as we move into 2021, it's changed to 0 and 100. So it's basically eliminated the request for anticipated payment, and now the wrap itself really just becomes acknowledgement to Medicare that there's been one of their members have started care under home health. Also, just remember, since there's no money to recover, that wrap out of cancel rules no longer apply in 2021. The wrap requirements, they did change, but in our case, they actually got a little bit easier, which helps us when we start talking about some of the timing that are required for the wrap submission now. Physician's written or verbal order is received as one of the first requirements. And again, that's a little bit of a change, especially just having the verbal order. Still have to obtain it, still need to get it, but as far as the submission of the wrap, just a verbal order is required. And then the initial visit for the 60-day period has been completed. That does not mean the OASIS has to be completed. That means the visit needs to be completed, which basically admits that patient to home health care. Subsequent wraps do not need a billable visit in order to bill. And really what's going to happen there is as the start of the second billing period begins, that's the date that's actually going to be reported on the wrap. So the start date does not have to match up to a visit date. And then submission timing. This is a little bit, we're starting to talk about this, but right now wraps for both 30-day periods can be submitted together. Now, of course, there has been some issues with that, with the processing and CMS, and Nick's going to talk about that a little bit later in the presentation. So let's talk about that late submission penalty. So one of the things that changed was that there was a requirement for the wrap to be submitted within 5 calendar days, or a payment penalty was going to be introduced. Now that penalty is calculated as a day penalty, or 1/30th of that billing period for each day that it's late. And that happens after the 5th calendar day, and we're going to start counting the first initial is day 0, so we'll count that day. Although they will calculate the first 5 days, and we'll show you an example of that calculation later on in the presentation. Also, the adjustment reason for 95 that's going to come into play, that'll show you that there has been a late submission, and that's what the adjustment's going to happen to the payment. They did allow for some exceptions for late submission, and I'm glad that they did, because we are going to actually probably have to use some of this in the first quarter. The 4 exceptions include acts of nature. Of course, we have hurricanes and tornadoes and anything like that that may have prohibited or been a block to you actually submitting the wraps. We also have CMS and MAC system issues, which is something that we're experiencing right now. And some of the advice that we're seeing from CMS and the MACs is to actually use one of these exceptions to resubmit those late wraps because they're not getting into the system. And then newly certified agencies, and this is really for those agencies that have a retroeffective date. And so you have wraps that may have been past that 5 days, and you can submit those still without a penalty. And then the catch-all at the bottom was other situations beyond the agency's control, which basically goes back to the last thing, is that remarks have to be included with a KX modifier, and it is for consideration by the MACs. It is still up to the agency to prove that one of these exceptions was the reason that the late submission occurred. And then value codes, the CBSA and FIPS code are optional. What we found out is that there is some process issues there, and they are required at least on a couple of those codes. And again, Nick's going to talk about some of that as we move into the presentation. A couple other things that changed a little bit on the diagnosis. The only diagnosis required is the primary diagnosis, and it has to be a valid primary diagnosis. All the others are optional. And one thing that's a little bit different is that the diagnosis on the wrap does not have to match the diagnosis on the final claim. And that really becomes because the wrap really does not affect the payment of it, and the diagnosis on the final claim is ultimately what affects the payment. The HIPS code, that's something that's been a very complicated issue to deal with, especially through your EMR systems. The HIPS code submitted on a wrap can be any valid HIPS code, but the HIPS code on the wrap and final must match. That's to ensure that they have both the wrap and final as it's set up right now on each billing period. But ultimately, this third line about the Medicare payment is ultimately Medicare is going to calculate the HIPS code that affects reimbursement. So that's going to be based on the diagnosis code. So that's going to set the clinical grouping and the comorbidity adjustment. And then also from the OASIS, we're going to get that's submitted to iKeys. We're going to get the functional impairment score. And then, of course, you'll look at the common working file for claims to determine source and timing. That's going to generate the appropriate code, and that's the reimbursement that's going to occur. Nick, you want to talk about some of that payment penalty calculation and example?
Absolutely. Thanks, David. And hopefully you all don't see too many of these. This is the payment penalty, and I think this is a relevant slide just to walk you through the example for more reasons than one. You know, number one, we want to make sure everyone was on the same page with how the calculation works. But number two, we should be coming up right now to really starting to see a high volume of those initial final claims that are applicable to the new rule process and pay really in the coming days. We've already started to see some of those claims that might have had a shorter than a 30-day period that discharged before that, where those claims were submitted towards the end of January, and now we're coming up on processing times. But if we think about it logically, any of those 1/1 wraps that would have had a period end date of 1/30, if you were submitting those claims on 1/31, you're pretty much going to have those claims process and pay here by the end of the week. So keep your eye out for any kind of penalties that are valid or invalid. As David mentioned, and we're going to talk about this in the coming slides, we have definitely seen a variety of issues so far as it pertains to CMS processing of the new wrap. So for a payment penalty calculation here, David mentioned this earlier in his slide, the period start date is actually counted as day 0. So when you're going through and you're trying to figure out, all right, I have a patient got admitted on 2/1, how quickly do I need to get that wrap out? It's not 2/5 to get the wrap out. You know, 2/1 is counted as that day 0. So you actually have until 2/6 to get your wrap submitted, and it's still within that timely filing window. The payment penalty itself, though, is going to retro back to the begin date of the period. Another kind of common misperception, I think, as agencies were starting to get educated on it. So essentially, that payment penalty is going to be 1/30th of whatever your HIPS code value is, and it retros back to that start date. So if you had that example I said where you had a 2/1 start of care, you didn't get the wrap out by 2/6, let's say you didn't get it out until 2/10, well, that penalty isn't going to go back to that 2/6 date. It's going to go all the way back to 2/1. So in the example we have here, we're going to use 1/1. 1/1 is the admit date. The wrap submission date is 1/10, and we're going to even count back to 1/1. We're not, you know, that's counted in that payment penalty. It's not counted as that day 0 when it comes to the actual penalty amount. So it goes back to 1/1. The submission date itself is going to be a covered date. So essentially in that example, you would have 9 penalty days. You take 9/30th, so whatever that HIPS code amount is. In this example, we're going to use $2,000 for the HIPS code amount. So you're going to have a $600 penalty, and that's going to show up on the claim with a value code of QF and then the dollar amount associated with it. So you'll have your total payment, you can see there, of $1,400.
Nick, if you don't mind, I'd like to jump in with one question, because
Sure.
somebody wanted some clarity on this. So we got a question that says, did I hear correctly that the first billable date does not need to be the first date of admission? Line item 0023 needs to match the first billable date, question mark.
Nice. That's going to be a very topical question for what we're uncovering. That's one of the confusions I think going on right now. The 0023 date, as it was explained to Medicare heading into January, on your wraps is always going to be the start date, or as they say in the reg, it may be the start date. Now, we know that we can, as David said, we can submit wrap number 2 the same day as wrap number 1. In the pre-2021 world, that 0023 wrap date always had to match the first bubble visit. But we know that in those subsequent periods, some instances, I would say in many instances, that first visit may not be completed in the first 5 days. So you wouldn't be able to have a timely wrap. So that was where Medicare came with the guidance to say the 0023 date on the wrap may match the start date. So we've been going with the understanding that all wraps essentially now get billed with the same 0023 HIPS code date as the actual start date. Now, where we're coming into issues, and we'll get into this in a couple slides, is that we're seeing some incorrect rejections or RTPs in instances where that final claim has a 0023 HIPS date as the first billable visit, which Medicare has clearly stated that that should be the case. So our understanding is that your 0023 date on your final isn't necessarily going to match your 0023 date on your wrap, which again, in the pre-2021 world, it was a no-no. But in the new world, it's supposed to be acceptable to be able to do that. It's one of the several errors that we'll cover as we go through here and kind of what we're hearing. So a good segue into this next slide here. So what do we know so far? So in terms of what we've seen, a couple of early observations. I know that one of the major questions we had going in is how long is it going to take these wraps to process? Is it going to be almost like an instant processing and payment, even though it's a zero payment, basically go to that PB 9997 status almost instantly? Or is it going to be the typical 3 to 5 days that wraps were processing in the 2020 and previous world? What we've seen so far is it's been similar to what it was before. It's taking 3 to 5 days for these wraps to process and pay, even though we have a lot more limited number of data elements, and also there's no payment being issued. What are some of the other issues? That's the next piece here is the issues that we've been seeing. So a lot of these have been acknowledged by Medicare. Some of these have been fixed. Some of these have an estimated fixed date. Some of them are brand new. As David had mentioned at the top, I think we updated this slide deck 4 times in the last 4 days, just as new issues were either being uncovered or there was more clarification coming out. Here are some of the ones that we wanted to include in the slide deck. One of the ones that we saw early was what David was referencing before, was this value code 61. So again, all the documentation, the language prior to January stated that that was an optional code. And what we were seeing in the very infancy stages of 2021 was that these wraps were going into RTP when they were missing that 61 value code in the CBSA in error. Again, remember they said it was an optional piece. They were getting RTP'd in error. It was a quick fix. All you had to do was put in that 61 and then the CBSA code and just send it back through. But it was also a time-consuming process to fix if you had a high volume of these going out without it. So they've since put a fix in place so that there's a new reinstatement that you don't need to have the value code 61 on there. But again, it was a bit of a disruption from the get-go. A couple of the other issues we're seeing, and again, this slide is more specific to wrap issues, is this value code 7216, and we're seeing a number of different issues specific to this. Essentially, what this reason code is, it's situations where the 0023 line differs for the wrap and the final claim. So similar to that situation that I explained before. So we did see this specific example happen for crossover patients. So what I mean by crossover patients, so those are going to be patients that had a start date in 2020 and an end date in 2021. Now remember, if it started in 2020, the old RAP rules apply. And if it started in 2021, the new no RAP rules apply. So as I mentioned before, in the old RAP world, your 0023 line on your RAP is going to be your first billable visit. In the new RAP world, that's not going to be the case all the time, especially for those subsequent periods. So there was instances where Medicare was incorrectly putting these claims that had the RAP date starting in December when that first billable visit wasn't until January. So again, let's say you had a patient where that subsequent period started on 12/28, first visit under that period wasn't until 1/3. It was putting those RAPs right now are incorrectly in RTP. So that's still an issue. No fix has been put in place just yet. So if you do have an RTP and reason, if you're starting to see your RTP log creep up, and that's something that we monitor for all of our projects, is to see what that count is. Some of these issues might have been identified and you just can't fix them yet, this being one of them. One of the pieces we are suggesting as you're going through and fixing these RAPs, especially for the new RAPs, is if you do have a claim in RTP and you go to fix it and it's outside that 5-day window, you want to make sure you're taking a screenshot just so you have proof of what the receive date was, because when you do go to make that fix on the RAP and send it back through, it's going to change the receive date in Medicare system. So let's say you had a 1/1 RAP, you submitted on 1/3, hit RTP on 1/10. You're just figuring that out now, and I'm going in to fix it now. If you went in to fix that and send it back through today, it would show as a receive date of 2/10. So it's going to look like it's way out of timing. So again, take those screenshots to make sure that you have the proof that it was received on time.
Hey, Nick, one thing that I wanted to mention here too, because I don't know if you saw this on your side, but we saw it. That one flag that kind of made this we knew that it was something related to the no pay RAP was the use of that W7216. That's something we haven't seen in quite a few years.
Correct.
And so it just popped up, and we're starting to see some of these reason codes that they're using are just way off reason codes and I assume it's to kind of put them all together in one spot, but that was an indicator that it was something related to the no pay RAP.
Yeah, and to piggyback on that, I think for the billing folks on the call, they're probably used to any situation where a RAP, an indicator on a RAP didn't match an indicator on a final, whether it be a date or a code. You typically see that reason code of 38107, which is kind of the final claim mismatch from the RAP. To your point, David, I think they've been more categorizing these into unique scenarios, like in that example, that's specific to the 0023 date. Where it's not always, just using that 38107, it's more the W7216. So some final claim issues. So we've seen a couple of these pop up, and again, knowing that the final claims are still very, very much in their infancy stage. A couple of the first issues that we identified, we were wondering if they were specific to LUPAs, but the more we thought about it, the ones that we were identifying were LUPA claims only because they weren't full periods. And for those claims that were, let's say, started early January, discharge mid-January, processed and paid end of January, the high likelihood of those patients is that they were LUPAs, because they're going to be, with a short length of stay there, they're probably going to have low visits as a result, and in all likelihood be LUPAs. So we still haven't confirmed if these are specific to LUPAs or if they're just specific to all periods beginning and ending in 21. So this first one here, this is actually more specific to an issue that they were having with Oasis. So there was a period of time there in the beginning of January from the 4th to the 8th where all Oasis that were submitted to iKeys were not showing up as received. It's since been resolved, and again, for this instance, there is an RTP reason where it's not seeing a matching Oasis to go with the claim information that they need in order to actually price it. As David had mentioned, you're going to need that Oasis info to figure out what your functional score is. So you need to have that Oasis on file in order to submit the final. Again, an issue that they acknowledge they fixed, and now you should be good. If you still have claims that are in RTP for that reason, you should just be able to go through and send it through, go into the claim itself in Medicare's RTP file, hit F9 to send it, and it's going to process and pay without issue, hopefully. The other one there, go ahead.
Sorry, we have another timely question here,
Sure.
I think.
Perfect.
Somebody wants to comment that they recently tuned into a Palmetto webinar, and Palmetto recommended resubmitting the wrap if you see it going to RTP. Based on what you're seeing and hearing, do you agree with that practice?
Well, it depends. So I would say if it's one of the issues where it's specific to the wraps beginning in 2020 and ending in 2021, that makes sense, because that's going to be within timely filing, right? You still have a year to submit those wraps from the end of with start dates in 2020. If it's a 2021 wrap, if you submit it today and it's, let's say, a 1/1 start date, it's going to go into RTP for or it's going to process, but your final claim is going to have a payment penalty associated with it. So you're going to have to go through the process of using that KX modifier and with the comments to try to get that process through. If it's still within timely, let's say again you submitted your wrap today for a start date of 2/9, hit RTP, you want to submit another one, that's acceptable practice, but I would try to submit that out of RTP first, since you're still within those timely filing deadlines. So if you see that second bullet there, the next reason, that 37363, this is the issue that I think is specific to LUPAs. I've only seen it for LUPAs. I know that one of the MACs at least is acknowledged it's just for LUPAs. So this is the final claim incorrectly going to RTP for a late wrap. And I don't know if it, the handful of scenarios I've seen for this has been a specific mid-January start date and a mid-January submission date for the wrap. The final claim, again, it's the final claim is going to RTP saying that the wrap was filed late, which again is also a little confusing to me, because my understanding was that the final claims would process and pay. You would just have that modifier on there and indicate the value code rather, and indicate what the payment penalty is. So my indication was that those weren't supposed to go to RTP and they were supposed to process through. So I think that's, again, just a glitch in Medicare system. Again, one that they are aware of. So just keep your eye out for any RTPs for that reason. All right, a couple new ones. So this top one here popped up last week. So this is a situation where if you had a wrap that was submitted earlier than 5 days from the from date, they are incorrectly receiving that timely filing penalty. So again, let's use the example on 1/1, you submitted your 1/1 wrap. You also submitted your 1/31 wrap, because Medicare's rules state that you can now submit your second wrap on day 1. That would have been considered, based on this error, as not timely. So there's some organizations with some questions I've gotten. You can see here they're actually going to correct this issue by 3/1 is what they have said. Until then, organizations can continue to submit their claims and expect an adjustment on that full final claim payment. There's been some questions here on how should we handle this as an organization? Should we continue to bill wraps as is? Should we hold off on billing those subsequent wraps until they're within the 5 days of the start date? I would say for these, continue to bill the wraps as is. The reason being, if they're truly going to fix this on 3/1, and fingers crossed that that's actually going to happen, if you're identifying this now and you had let's say a follow-up wrap that you could submit today for a start date of 2/20, let's say, that final claim isn't going to be able to even build until the end of March. So the damage has been done on this issue. If you've already been billing the wraps prior to, any of those subsequent wraps that are going to be impacted by this, by the time you bill that final claim, the fix will already be in on 3/1. So I would continue to bill as is. A couple other issues, I'll address this last one, this last bullet, and then also another new one that popped up that I want to just talk about. This is one that actually just got identified and hopefully resolved yesterday. So as of late last week, we're noticing a 2% penalty, payment reduction rather, for all final claims that we figured out were final claims that had started in 20, ended in 21. So there was a lot of questions going back and forth and exactly what happened. Was it some kind of an error with, being the fact that it was 2% exactly? Was it some kind of error with sequestration not getting extended like it should be? We know that got extended, the relief on sequestration, through the end of March. What it ended up being is an error in the pricer program. So basically, we know that the rate changes that take place every single year are applicable, and those standard rates are applicable to period end date. What had happened was the pricer that Medicare is using had based the 2021 pricer based on period start date. So if you had one of those crossover claims, again, the period starting in 20, ending in 21, you should be using the 2021 rates, which are 2% exactly higher than 2020 rates. Once we finally connected the dots, showed some payment examples to CMS, we work with NOC on trying to get this resolved. They looked at some of the examples, walked through the logic, figured out exactly what happened. We kind of showed the regs that clearly state that the new rates, even with PDGM being put in place, the standard rates still apply to period end date. They agreed, acknowledged the issue, and are going to be communicating back with the MACs. So you should be seeing some communication come out on that here in the coming days. Not sure when this is going to be completed in terms of when they're going to go back through and adjust those claims, but if you're noticing some of those crossover claim payments that have been 2% less, know to keep those balances out on your AR and that they're going to get adjusted at some point in time here. The other issue that I wanted to bring up too, before we go into that, sorry, David, this is my fault for not including this bullet, is what Bob had referenced before. So we're starting to see more issues pop up now with the mismatch as these final claims are starting to get billed, where the 0023 HIPS date on the wrap was the start date, but guess what? It didn't have a billable visit to go with it because it was a subsequent period, and now it's hitting RTP for a mismatch in those dates. So again, Medicare today acknowledged, at least again, one of the MACs did, that this shouldn't be the case. So they're researching it. So look for news to come out on that error specifically here soon and what the fix is. And again, these are going to have to, that one will have to get resolved pretty quickly, as we're going to start to see some of that final claim volume increase pretty significantly.
Hey Nick, I think the other thing, just kind of what we're seeing right now as far as the process of what happens when they identify one of these issues, at least what we're seeing is that you'll start seeing these issues come up or pop up, and then at some point in time, you'll see Medicare or one of the MACs acknowledge it. It's not going to be a formal acknowledgement, but they'll acknowledge that there's a problem. It'll take a few days. They'll actually publish exactly what the problem is, and then it'll take a few days, and they'll come up with the fix is. So it's something that kind of evolves, and we, even when we were preparing this, we were seeing it because we'd see something a couple of days before, then we'd get some kind of acknowledgement in some kind of posting or response that we received, and then you'd see a formal one, and then of course they would have a fix. A lot of times they're pushing it off until the dark days, March 1st, where they'll make a system change and adjustment that will correct some of these things. Some of them, like I said, are fairly easy for them to fix, and they're doing it on the fly. So that's kind of the process that we're seeing through these issues.
Yeah, and I would encourage you to definitely go out on those MACs, like even the ones that aren't your MACs, go on their MACs to look at the claims processing issues log, because to David's point, they're not always all on the same page with how quickly they're updating. For instance, that 2% one that I just referenced, the bottom bullet there, that's already on CGS's claims processing issues log. It's not on Palmetto's yet. I'm not sure about NGS's, but even CGS has it flip-flopped. They're saying that they're paying it at 2020 rates incorrectly. It really is, they're paying at 2021 rates incorrectly. So hopefully they update that here soon. But definitely check those claims processing issues logs to see which of those issues. Typically, if one MAC's having the issue, they're all having the issue, especially as it relates to new regulations, because a lot of times they're specific to the pricers that they're using. So, again, something to make sure that you're checking, and again, don't just limit it to your intermediary. Just check all the intermediaries, all the MACs, to make sure that you're capturing all the issues. This next slide here we thought was interesting. This just got published by Decision Health a couple weeks ago, and showing the wraps time submissions. I think a lot of these numbers will change, obviously, going forward as we get more into 2021. But it just shows the challenges agencies have with the timeliness of RAP submission. Obviously, these numbers will go down significantly, but you can see the highest percentage of days from start of care to actually bill the RAP, days to RAP, is that 15 days or more. 22% of agencies said that going in. A lot of the misinterpretation that we saw in the beginning, and I still think we're running into agencies that have the misinterpretation of exactly what needs to be happen in order for you to bill a RAP. Some agencies are going with the approach of we need to have our OASIS locked and submitted and have all the same documentation that we had in place that we needed to in 2020. That's not the case. You just need to have that first billable visit, that order, the initial order, and then that primary diagnosis code. So make sure that, if you've changed your practice completely, I mean, it's great if you're getting those RAPs out, including the OASIS submission within 5 days, but you don't necessarily need to have that OASIS completed and locked. You can bill with the generic HIPS code, and that HIPS code is going to auto adjust in the EMR, and then also auto adjust what the payment needs to be at the final claim.
So Nick, just to make sure I'm looking at this correctly too, we're saying here that the vast majority of home health agencies out there are getting hit by these late RAP penalties right now, correct?
So I would say this is more likely going to be a leading up to 2021 RAP time study. So I'm not sure exactly what the time period was, but this is very reflective, I think, of how agencies operated in the pre-2021 world, just with how long it was taking RAPs to get out the door. So I don't think this necessarily applies to 2021 RAPs, if that makes sense.
Got it.
So, and that's a perfect segue, Nick, and jump in. We talked about operational process changes, and I know we had some webinars that we talked about this prior to the January 1st. But if you haven't looked at some of these opportunities to change your processes, these are some of the things that could definitely help adjust to the new no pay RAP. The clinician must lock the start of care visit in the EMR within 24 hours. Again, this is part of, that reduction and change of the requirements for the submission of the RAP was done explicitly to be able to help that timing. So, separating, OASIS and the start of care, that visit was a big key to be able to accomplish that, so that you still have time to accomplish your paperwork and your documentation that's still required, still have to submit that OASIS, and all that has to be done. The final requirements are the same, but it just releases that requirement for the OASIS and that start of care at the very beginning, so that you can just get the visit accomplished in a quick time frame. Faster that you can get that, the faster that you can get that process in. And what we see on our side, a green submission time frame is about 2 days. So the faster we can get that done, the quicker we can get the submission done. Intervalid prime. Go ahead.
I was going to say, David, I think a lot of this also goes back to accountability, right? I think, where agencies have struggled in the past is holding those clinicians accountable to making sure that they are locking that visit in there, or even getting out and making the visit. I think that one of the fallouts from the new RAP rules is kind of heightening that accountability, which you want to have that visit completed timely anyway, and you want to have that documentation completed timely. So this is, just another way to enforce why that needs to happen.
Yes, and a lot of these things we see, are attempts to try to enforce things that are probably best practice in the first place. So, that's a lot of things that we're seeing through, some of these changes. Intervalid primary diagnosis code from referral at intake. Again, the primary does not have to match the final, but it is a valuable component, and it is something that we really talked about, changing and putting some focus on the referral and that intake, and making sure all the information that we can possibly obtain that we do, that even coming from looking at where the source and the timing of that came from, because that now affects your reimbursement. So the better that we can do at intake, the better off we're going to be at not only understanding what that episode is going to be, but also, at least making adjustments as needed as we come into creating an opening and admitting that patient into care.
Yeah, I would say one question we always get is, all right, what if the diagnosis we're getting is still that muscle weakness generalized or not an acceptable primary diagnosis code? I would say in most cases, call it 90+%, you're going to be getting a valid primary diagnosis. I think one of the pieces we did a great job with leading up to PDGM is educating those referral sources and what constitutes a valid primary diagnosis. If you didn't get a valid primary diagnosis and you're still struggling to get that out within 5 days, keep in mind it doesn't need to match the final. So if you need to use the closest that you can get to before the actual diagnosis coding takes place, that's an acceptable practice. Again, keep in mind that the diagnosis, Medicare is not looking at the primary diagnosis on the wrap. They're only focusing in on that primary diagnosis on the final. So our recommendation there would be to have just again use the diagnosis as closest to it's going to get ultimately updated to what the actual valid diagnosis code you're going to use for billing anyway.
Absolutely. Increased billing frequency of wraps to daily, and that is something that we've seen and recommended for some time. Those wraps we should probably get out daily all the time, and even consider Mondays and Fridays, maybe doing 2 batches and watching those 3-day weekends too, because that becomes a big one. This is something that we've done, on the hospice side, because you had the NOEs before, and it's always something that's a good practice to make sure that you're just processing those things. Again, with the relaxed requirements for the wraps, this becomes a much more reasonable ask and consideration to be able to do these on a daily basis. And then, we'll talk about, once you do those, then you can kind of monitor those and see where you're at all times on ones that need to be submitted, ones that have been submitted, and making sure that you're processing those through, timely, and you're addressing them timely.
Yeah, I think to your point, the high referral days or the high referral periods of time are the ones where you want to have that high frequency.
Yep. So in reviewing the RTP file daily, Nick kind of talked about this, in one of the questions, I think, Bob, that you had. This is something, if you're addressing and reviewing those RTPs quickly, a lot of times the fix to those can be just a matter of refiling those or re-entering those and making sure that you're under that time frame. But if you're not doing that, then it may add a step or two that you have to do. Again, the point and the pressure of proving that there was an exception to this penalty is on the provider. So there's some efforts that may have to be taken to make sure that if you're going to go through that, and as we're having issues that we're seeing, so making sure that you're reviewing that RTP file daily and making sure that you're getting those in is a big operational practice that can help you save some time and effort in the long run. Also looking at determine alerts and EMR to notify wraps at risk on timely filing, and then also a wrap tracking tool for submitted wraps. So that's both ends of the spectrum. You really have to keep an eye on those ones, with 5 days and a lot of things going on. It needs to be easy to see and easy to monitor to get those ones that are in 1, 2, 3 days, on the front end. Although those submission, like you said, is really the 6th day. I mean, we're going to consider 5 days is late. We need to get those in because there's all kinds of issues that possibly could come up. And even though there might be an opportunity to recoup that money or that 5 days of penalty, sometimes it may take some time, and I can imagine as the year progresses, they're going to be a little bit more stringent on that timely filing as it moves on.
Perfect. One of the other pieces we wanted to show here is, a lot of the discussion we had leading up to January 1st was just how the cash flow is going to be impacted. We know last year we had a huge impact on cash flow, just switching from PPS to PDGM, going down from those 60-day episodes to the 30-day payment periods, wrap values changing from 60% down to 20%. And we had another anticipated cash flow hit with the change to the no pay wrap. So wanted to first show you an illustration of what we put together for what we were seeing, what we were expecting to see, and then a kind of here's what we already have seen in January based on some analysis that we've done preliminarily. So this just gives an illustration on the cash flow impact for changing to zero pay. In this example, we're going to use a one wrap, one final claim assumption per day. No case mix wage index or volume changes from 2020 to 2021. You can see the standard rates there, which are the exact standard rates for Medicare system. In this illustration, we're going to say days to wrap are going to change from 7 days to 3 days. For days to final claim, they're going to stay the same at 10 days, days to pay the wrap at 7, and days to pay the final at 14. So if we look at this illustration, it really shows you where the impact and where the cash is going, and when it where it's gone for the no pay wrap. So if we look here, you can see here, obviously all your December cash is going to be 2020 wraps and finals. You're going to have some carryover of the 2020 wraps into January. And in this example, we're going to say, in this illustration, we're going to say there's none of those dollars coming in February. The 2020 PDGM final claims are going to continue on through February. And then you start to see, the line that shows the 2021 wrap cash, which we know is zero, and the 2021 PDGM cash, or final claim cash, which is really not starting until this month of February. And what this shows is about an 11% reduction for what we're estimating for January. Again, that's just simply based on the fact that we're changing from getting that 20% payment down to zero. If you think about it, if 20% of your cash per month in 2020 was wrap cash, and we know that, we'll call half the month of January, we still have some of that influx of December wraps, half the month we're not, that kind of shows you where some of the logic comes in there. It's about half that amount. The important thing to note here is that cut gets even deeper in February. In February, we're not getting any wrap cash at that point, and we still haven't really realized the 100% value of the final claims of 2021. Again, just kind of talking through it logically, if you have those those early January starts, they would have ended at the end of January into early February. You're probably not billing those out until 10 days after, like we had in that calculation. And those first payments really aren't going to be coming in until later in this month. So you're not really realizing that full period month. You start to realize and normalize what that cash looks like in March, but that cut's going to be even deeper in February. So something to be aware of. Again, if you're taking a look at what your cash flow in January was and you get surprised at how much lower it was compared to what your December or your Q4 average cash was, that was something that should have been anticipated. And again, the other takeaway from that is to know that cut could be even deeper in February. Now, we have an actual slide here on the next slide, which shows really what we've seen for the top 25 size clients that we're intimately involved in doing some of the billing and collections work. You can see this slide shows it was an even deeper cut in January. So we're hoping that means it starts to rebound in February. I think a lot of the reason why we had such a deep cut was revolved around some of the payment issues we've been experiencing, some of those claims processing issues, add on the 2%. There's a number of different issues I think that have contributed to this. But this was a pretty eye-opening slide when we were putting together the actual numbers on it. You can see, we're not talking about, a couple of mom and pop agencies. We're talking about some pretty significant size. This was average cash for monthly cash in Q4 for these top 25 was about 120 million, and their January numbers came in at about 83 million, which is a 30% reduction. So we're talking some pretty huge numbers. The median there, about a $1.5 million per month agency that saw their cash reduce about 23%. So we saw, most of these agencies were seeing a reduction. I think, of the 25, 21 of them actually saw a reduction in cash. You can see here how we looked at the top 5 and bottom 5 in terms of percentage impacted. The bottom 5, it was almost a 50% reduction in cash in January. The top 5 did have a spike. A lot of that was based on timing and volume. for what they're able to bill out. Kind of that middle 5 we looked at, middle number was right around that 22%, the same as that median number. The 5 biggest agencies that we looked at had a cut of about 21%, and the 5 smallest agencies a cut of about 17%. So it didn't really look like size made a huge difference in terms of what that impact was, but again, something that I thought was pretty eye-opening. And if you haven't looked at your January cash, which I'm sure you have, and compared it back to what your average monthly cash was for Q4, you should definitely go through that exercise. Again, hopefully some of these payments pick up in January and February as some of these claims processing issues get resolved, but also keep in mind February is a short month. So you could be in a situation where your February cash, you don't start really digging out of that hole until March. This again is just another illustration of why it's so important to have that forecasting and make sure that you're managing your cash flow as well as possible.
And Nick, this kind of is starting to mirror kind of what we saw with PDGM from the reduction of that 60-40, 50-50 split to here. Timing is about the same, that the impact was really February, March where we really felt it.
Exactly. The timing, I completely agree. I think that this has been a bigger cut. From what I've seen, I would say Medicare's processing systems handled PDGM a lot better than they've handled the no-pay wraps. I think that's been the biggest difference, looking from a year-over-year comparison.
Yep, I agree. So talking about some technology features that could help support this change, one of the things is the support of $0 claim reporting. I mean, that is a simplistic statement, but sometimes that's the big thing, is that your accounts receivable, and when it goes there, you don't want your accounts receivable to be showing a dollar amount for a wrap when there is no dollar amount coming, so that you can prepare and kind of make some of those adjustments for those cash flow changes. Also supporting multiple HIPS codes. We've talked about, the HIPS code for the wrap and the final have to match, but there's also that HIPS code where you're calculating that expected return of that reimbursement. So there's multiple different HIPS codes that come into play in the system, allowing you to do that and be able to monitor that at the same time. Definitely helps to make sure that you're not mismatching those HIPS codes. Also, easy to monitor wrap aging. We talked about that on a couple of slides before. That is a key component, and be able to look at a countdown for those wraps for that 5-day measure, and then also kind of looking and monitoring once they're submitted, so that you understand, where they're at and what's going on. And that also, we've able to see some of those wraps that you may have pre-submitted, so you can count down those days too. That was an easy way for us to monitor and see some of those changes as we saw the system issues pop up, not really understanding that these were pre-submitted versus submitted after the 5 days. It was just outside that 5-day period. Separate initial visit and OASIS items, that's a key component. There was a lot of requirements that were set on the wrap that were locking down those two to make sure that OASIS was locked and ready to go before that wrap submission occurred in previous years, or before this. So being able to make sure that those are separate and you can deal with those separately is a big component. Also making sure that the adjustment reason can be tracked. A lot of the times as we see this, really understanding what impact the penalty is having on your revenue, because remember, this is not potentially just a cash flow change. This could be a revenue change. If the adjustments aren't made, and if those numbers that we saw reported are actually accurate, and we're seeing 22% of the agencies not being able to submit it timely and losing half their reimbursement, this could be a revenue impact. So being able to monitor that's a key component. Also making sure that the addition of modifiers and required remark sections in your claims is a key component. That's not necessarily something that's been able or out there on everything, but that is a key component as we get through, especially these adjustments and changes during the first 6 months of this, as we might see continued system issues. Faster entry into the Medicare systems. So, we talked about, don't be afraid if you're worried about the timing to go ahead and directly key in these systems. Sometimes these submission processes, if they're going batch, may take a day or two before they actually get into the Medicare systems. And when we're talking, 5 days, that's a lot of time. And then submission of both 30-day period wraps. Nick, we talked about that this is a problem right now, but the advice is still to do it, because although those system issues may be corrected and may cause a little problem right now, I think not getting into the habit and getting those days and be able to have your system to allow that to happen is going to put you at more risk than just kind of dealing with this situation right now. So what else to expect in 2021? So remember, we are still in the COVID world right now, and there are still some things that are delayed and changes that are coming through. PDGM kind of has gone through this whole process in the public health emergency, but just remember that we March 31st, a lot of the things that were discontinued or delayed will be coming back out, and we'll see probably the way that it would have done and happened in last year, January 1st last year, kind of come through. So the RCD, or review choice demonstration, again, everything was put on delay multiple times during the year. This last time they said that they were going to delay it until March 31st, but that will begin. The good thing, what we've seen, is that most providers are continuing to submit pre-claim review. They're still going through the process. And again, that just means that those claims will be not subject to any further medical review, and getting to those next level in RCD will be easier for them to achieve. So again, this will start back up, though, wherever it left off as of 3/31/21 so far. That's the last information we've had from CMS, and it looks like that probably will occur. Medicare Advantage plan changes. That is something, and we saw this last year as PDGM kind of rolled out. We didn't get a lot of communication from the Medicare Advantage plans, what they were going to do and how they were going to do it. And then when we did get that information, what we found out is that they were not quite 100% adopting the Medicare regulations or processes that were out there. So we expect to continue to see that this year as Medicare Advantage adopts to a no wrap kind of scenario, but we're not exactly sure how all of this is going to occur. You got to remember, two parts of that wrap. You've got to send the notice of admission, and you actually get payment. Well, a lot of the Medicare Advantage plans were not paying already, but they still have to have a mechanism to make sure that they get that they know one of their plan members has entered into home health services. And then finally, the final steps to PDGM will be the elimination and discontinuation of WRAP as anything, and change to an NOA, or notice of admission. And this is very similar to the notice of election. We believe that we'll start seeing, and there'll be some changes on the documentation and forms that are out there. So that will change, but there should not be any significant financial impacts to this. We expect that to be just kind of the final steps and stages as we go and move into that in 2022. Anything else I missed on that, Nick?
I don't think so. I think your point on the Medicare Advantage is definitely a good one. Just a lot of uncertainty, and even as you're reaching out, you definitely want to get in writing kind of what their plan is, how they plan to approach it. And I'm sure you're starting to see more and more, what the answer on that is. I would say the most common response we've heard is that when you are getting clarification on how they're handling, is that they are adopting the zero pay aspect of it, but not necessarily the timely filing on the wraps of 5 days. So again, something you want to get clarification on, because if they are adopting the 5-day timely filing, you obviously want to get those wraps on file, but it's also important to have a valid HIPS code for them, because they don't have the Medicare pricer where they're going to update the HIPS code based on all the claims information. They're going to be basing their payment on exactly the HIPS code you submit. So important to know how to build what they're planning to do.
an important point there to call, because there are some of them that do post it, but not the majority of them. You know, some of the larger ones will post that process in their billing system and their operational websites, but for the majority of them, it's going to be a call and word of mouth. Well, that's the end of our presentation. Is there any, Bob, is there any additional questions out there?
There are quite a few questions out there. We are at past the hour, so let's kind of do a lightning round Q&A session here. We'll get to as many as we can, maybe in the next 5 to 10 minutes. I'll start with some pretty straightforward ones. Somebody's asking, if we were a new agency and due to our new status, we never received that 20% reduced wrap last year, are we correct to assume our cash flow should not change at all? I think, and they're asking, going back to the one chart we had with cash flow from month to month.
I would say yes, with the caveat that one of the big changes, I think, one of the big impacts, I think, on cash flow was just the Medicare claims processing issues. So there might have been some delay in payment because of those processing issues, even though you weren't getting paid the wraps before. Again, based on our assessment and based on our analysis, we thought it was going to be closer to about 10%, and in reality, it was closer to 30. So you probably, you know, let's kind of split the difference there. You might have seen a 20% reduction, or use that median number, that closer to 20. You might have seen a 10% reduction in cash flow just because of those processing issues.
And just to make sure that you don't, that the timing, the penalty still, you know, comes out on the final. So make sure that you're getting those timely.
And somebody wants to know, if we submit a second 30-day wrap in the first 30 days and end up discharging the patient prior to the second 30 days starting, do we need to do anything with the second 30-day wrap that you previously submitted?
You do not. You do not. No, wrap auto cancel rules don't apply anymore. Yeah, that was the reason why they had those wrap auto cancel or cancel rules in place before, is because there was obviously an exchange of funds that took place. But Medicare's guidance has been you don't need to do anything with those wraps. Once you submit your final claim for that period, it's going to flag it in Medicare's common working file that that patient's been discharged, and then any agencies that may pick up the patient afterwards shouldn't have any issues. It's another area where they have had some issues with is that, you know, those overlap situations, you know, where you need to submit with that condition code 47.
We talked about this a couple of times during the webinar, but somebody wants, again, to confirm, or they want clarification on this point. What if the primary diagnosis from submitting the wrap to filling out the OASIS changes?
Doesn't matter. So the wrap on the final does not need to match the wrap on the, or sorry, the diagnosis code on the final doesn't need to match the diagnosis code on the wrap. So in that situation, it's completely fine.
And somebody again wants to circle back to the 0023 issue. Please go over again the date on line 0023. Should be the first date of episode or the first billable visit. Also, the 0023 dates on wrap and finals don't need to match, question mark?
That's correct. So 0023 line on wrap is going to be the period start date. 0023 line on the final is going to be the first billable visit. Those dates are not going to match in a lot of cases. That's the guide. That's our interpretation of all the guidance. Again, I feel like that's probably the #1 confusion question going on right now, because there's been some claims processing issues when those dates don't match. But that is everything that's been written leading up to January has indicated that is how you're supposed to handle those situations.
Right, and the only thing I have clarity on that is the initial start of care. That's the admission date. That's really the only date that really counts. After that, it's really just a processing issue. That's why they allowed it to be the start of the next billing period. That's why we can do it at the front end, because it controls no reimbursement whatsoever, or any eligibility issues.
So it looks like a lot of the remaining questions were again about the diagnosis codes matching or that 0023 point. We do have a handful of other questions about what Medicare Advantage plans are going to be doing in terms of handling no pay wraps. Maybe let's end with this one, sneak one more in here. Somebody wants to know, so if we are using a fake HIPS code for the wraps, and this code also is on the final because they need to match. Why must the start of care be locked within 24 hours?
The start of care be locked.
So it's really the visit itself has to be completed. So that's the, go ahead.
Yeah, I think that's going back to our question on that. You need a first billable visit. So that start of care, maybe that's what that's referring to in terms of our recommendation on making sure that clinicians are locking the visits within 24 hours. Because that's one of the requirements for billing a rep is that you need to have that first billable visit. If that's not going to be locked in your EMR, it's not going to be able to produce a wrap.
Right.
All right. Well, sorry, go ahead, David.
Just clarity on that, and just to make sure, I mean, as long as that first initial start of care is done, that's the day that the admission has to be for the episode has to be done. So they need to make sure that that visit's done. After that, that's really the only purpose of that is to get that visit done and completed. The OASIS, everything else just goes on its own rules, and ultimately Medicare is going to calculate its own HIPS code. So it doesn't matter what the HIPS code, as long as it's a valid one, because it will kick it out if it's a made up one.
Exactly.
All right, well, that is all we have time for today. Thank you to everybody who tuned in, especially all of you who asked such great questions. Sorry we couldn't get to all of them, but we do have a list of all the remaining questions, and our two experts here will get all of those questions. So we'll have a really good pulse of what's going on, what everybody wants to know more on. Of course, before wrapping up, I want to say thank you final time to Axxess for making this conversation possible and for bringing Nick and David here today. Just in case you need a reminder, we heard from David Hoover, the Vice President of Revenue Cycle Management at Axxess, and Nick Seabrook, a Managing Principal and Founding Partner of BlackTree Healthcare Consulting. Final thanks goes to you guys. Thanks for your time today.
Great. Thank you, Bob, and thanks, David. It's been fun.
Yep, absolutely. Thanks, Nick.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on software advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.